Thiele.
Yeah, thank you very much for the invitation to come here. I think it's my second time. Last year I have been only online here at the meeting, and it's a pleasure for me to give the update on evidence of mechanical circulatory support in cardiogenic shock. And probably at first glance, everybody would say mechanical circulatory support is saving life, in particular in patients in cardiogenic shock. But now like always, I'm a little bit more skeptical, and I usually look into the evidence, and this is what I do, and then we can discuss afterwards what the evidence currently tells us. First of all, this has been introduced some time ago, so the SCAI shock classification, and this is what we currently use to have more granularity regarding the different stages of cardiogenic shock. And when we are talking true cardiogenic shock, then we talk about C, classic, D for deteriorating, and extremist cardiogenic shock. I've been one of the co-authors, and I'm still criticized this classification because it's a dynamic classification, and when you do it for a randomized trial, it's difficult to assess if the patient is in D, C, or maybe E, because in the cath lab, when you have to make a decision, it's extremely difficult to assess if the patient is in C, in D, because the patient may be deteriorating later on, or if the patient is in E. E is relatively easy. If the patient has lactate of more than 8, then we define it as E. But C, D, this is very difficult to define. Then it's also very subjective, because in the moment when you are using mechanical circulatory support, when you believe that you need it, the patient is in D. And everybody is doing it different. And this is also the problem in this classification. Now we look into the evidence. And I always have to show the intra-aortic balloon pump. When I would stay here 10 or 12 years ago, everybody would have said you have to use the intra-aortic balloon pump, because this was a class 1 recommendation in the previous guideline. Probably 500 times in my life I've shown these Kaplan-Meier curves. So the intra-aortic balloon pump does not work. And that's the reason why in the guidelines it's a class 3B recommendation to not use the intra-aortic balloon pump on a routine basis. I don't know what it does mean. What is a routine basis? So you're still allowed to use it when you believe in it. Nevertheless, our trial also had an influence on what we are doing. So we are using, in the United States, using less intra-aortic balloon pumps. They are using more impeller tandem heart. They are using more ECMO. And at the same time, you can also see the same, what is occurring in Germany, less intra-aortic balloon pump, more ECMO, more impeller. So this is a reflex, because we do not have any evidence that these active devices are better than the intra-aortic balloon pump. And this is what we look now for, looking for impeller tandem heart. This is what I always show. So usually what we need is randomized trials, meta-analysis based on randomized trials, and in case we do not have enough data, then we are using matched comparisons. And this is what I would like to show you regarding the evidence of mechanical circulatory support. So evidence from randomized clinical trials, impeller or tandem heart. We were able to do an individual patient-based data meta-analysis. No effect on mortality, some effect on blood pressure, positive effect on lactate, but significantly more bleeding with these active devices. So hemodynamic benefits, on the other hand, more complications. And currently we do not know if there's a balance between it, or maybe the hemodynamic effects have a better effect on mortality than the complications. Some more data. Now we have a little bit more than 200 randomized patients in active mechanical circulatory support versus control. We summarized this last year. No evidence on mortality benefit. So then we go for the next step, evidence from matched comparisons. I only restricted what I will show you of matched comparison of more than 100 patients, because matched comparison of 40 patients is probably not very meaningful. We all know the limitations of this. I always show this because these matched comparisons have problems. As you can see, so these two would be very nice matched, but we all would say they are not similar. So I summarized all the 5 match comparisons on one slide, and they are all very consistent. They do not show a mortality benefit with Impella. This one did not show any benefit. This is from Hamburg, yeah? But more complications, more deaths, more complications, more costs, more death, more complications, more costs, more deaths, more complications, more costs with Impella. This is the evidence. I only show the evidence. So I'm not speaking against the Impella. This is what we have. And there's a very recent, it has just been published 2 weeks ago. This is a 6 match comparison, once again, showing based on different statistical approaches. At least it does not show a mortality benefit with the Impella. It shows maybe higher mortality or at least neutral mortality. This is what they try to do with different models. At least it does not show a mortality benefit. Now looking for ECMO. We now have 3 randomized trials comparing ECMO versus control. 2 very small ones, ECA shock, 32-1 single-center trial, ECMO CS, this is currently the largest one, Euroshock, aimed at 428 patients, stopped early, just published 4 weeks ago. And you can see that there's no mortality difference for ECMO versus control in all the 3 medium or very small randomized trials. I just would like to point to ECMO CS. ECMO CS at first glance looks like ECMO versus no ECMO, but they allowed downstream ECMO, and there was a crossover rate of 40%. And this is what you also can see in the primary study endpoint. They used an unusual combined endpoint, including crossover, which automatically disadvantages the early conservative group, because in the moment when you have crossover to ECMO, it's counting as an endpoint. Nevertheless, no difference in this combined clinical endpoint. And you have to look for the mortality. Mortality, at least, is numerically higher in comparison to control. Once again, this is the evidence for mechanical circulatory support. In guidelines, it's in the ACS guidelines, it's 2BC to use it in refractory selected patients. Heart failure guidelines set it up or raised it up to 2A. I don't know why they have done it, because the evidence I've shown to you, if I would apply the evidence we currently have, this should be 3, because currently there's no evidence at all that we are saving lives. But we will have to wait what the evidence what it will tell us. Currently, in cardiac shock, only revascularization can reduce mortality. If we have multivessel coronary artery disease, if we stick to the culprit lesion only, it also reduces mortality. Catecholamines, maybe norepinephrine is better than any others. Intra-aortic balloon pump, clearly no mortality benefit. Currently, for mechanical circulatory support, no mortality benefit. And that's the reason why we have to wait for the larger trials, and they will come up very soon. So this is Euroshock, which has been published early or 4 weeks ago. This trial, Impella versus no Impella, currently is missing 8 patients, and they aim to present at ACC next year, so far I know. And I can already now tell you, because this will be announced today, our trial, ECA shock trial, will be presented at Saturday, the 26th in Amsterdam during the ESC meeting. So this is what I can tell you already. And then we hopefully will show that mechanical circulatory support is able to reduce mortality. I really hope it, but we will have to see what the results will tell us. Thank you.
Thank you very much for this very nice talk. Any questions from the audience? Nick, here.
Fabulous presentation, Holger, and great work in this area. You know, really, really important. And I think your summary of the evidence is spot on right now. That doesn't mean people aren't putting these devices in left, right, and center. And the reason they are is because of hope. They hope that by doing this temporarily, they buy some time for the patient. Ultimately, none of them are going to work unless it's a bridge to some form of definitive treatment where the underlying condition is reversible. How do you design a trial to show a benefit of something that isn't actually a treatment for underlying condition? And just interested in your thoughts on this really vexed, challenging area. Hopefully your trial will give us an answer, but...
I hope. So no, we don't know. So honestly, probably you have been also engaged in Euroshock trials. So the problem with them is also they were able to include only 35 patients in roughly 3 years. They say it's because of COVID, but I think it's also because many people hope and they believe that we have to use these devices. And I also know all the discussions with the ethical committee. So a long time they said it's unethical to do such a randomized trial. I recently also gave a talk to, in particular, surgeons. They say it's not possible that you are not using these devices because they save lives. But I said, you have been telling exactly the same 12 years ago with the intra-aortic balloon pump. It was, at this time, it was unethical to do a randomized trial with intra-aortic balloon pump versus control. It took us more than a year to get ethical approval to not use the intra-aortic balloon pump in these patients. Because I understand also, on the other hand, I understand the people who say, I hope that I can save the life of them. Because if you have 50% mortality, you want to do something. Yeah? And this is what we do. On the ICU, we do everything for the patient. And that's the reason why we insert these devices. And because we hope that it will save life. But we will see what the results will tell us. In case they are positive, the trials, then it's easy. Then it's exactly this is what we believe. We put in a machine, which is giving the patient 3-4 liters of additional circulatory support. This makes sense. And then it should lead to a better survival. But in case all the trials will be neutral, like the previous ones, or maybe even negative, then the discussions will be difficult.
Thank you very much. Do you think we include the correct patient population? Are these patients, they have probably reached the point of no return. It doesn't matter what you do, you will not get better. Would you dare say we should go earlier? I'm just speculating.
Yeah, good point. I believe that this is a great value of the Sky Shock definition. So now we have defined patients who are in pre-shock. And I think this will hopefully lead to trials where we do randomized trials in pre-shock patients. Honestly, regarding us, I know all the discussions. So this is what I can already tell you. In our trial, we allowed that patients who had undergone resuscitation before randomization were allowed to be included. Many people say this is not good because these patients have a very high mortality if they had undergone resuscitation before. But if you would exclude these patients, then the trial will not be generalizable because 50% roughly of these patients have undergone resuscitation when they present to the cath lab. And that's the reason why I personally believe we need large trials, maybe even larger trials, and then we have to do predefined subgroups, hopefully to define patients who have a benefit of this.
If there are no other questions from the audience, I mean, of course, there could be so many, but in the interest of time, so thank you both for the presentation and one more reason to look forward to Amsterdam.